Yeah. Okay, sir. Now that's a tibial tracker. One tracker pin is inside the wound and one is outside the wound. And the two tracker pins on the femoral side is inside the wound on the anterolateral cortex. Anterolateral. You should err more towards the lateral cortex, not on the anterior side, because your femoral is going to come here or your blade will be touching. If you touch your tracker pins, then it oscillates there and your readings will change. Okay? So, valgus knee robotics are very good because the chances of doing mistake on a conventional knee surgery by putting a femoral component in internal rotation is less. You can adjust your femoral component external rotation and your tibial placement you can adjust thoroughly on a robotic. Interesting discussion in the audience here whether to do robotic or conventional. You were listening here. A few months back I was in favor of conventional surgery against the robotic surgery. I was discussing with or arguing with Dr. Arun sitting there, and today I am crossed the border and I am in favor of robotics after a few months. Dr. Arun, you remember we discussed this on a Chennai meet. Am I audible?
Yes.
Shall we go ahead? Okay, we are going with the registration. The pins are there.
How many registration points you have, sir?
Only 2 check nuts are there. That screen there, see.
Dr. JV, you.
Okay.
Dr. JV, Ashok here.
Yes.
You use checkpoint always?
Yeah, always.
That's good, very good. It's very important to use checkpoints. Middle of surgery, the tracker moves, it can revalidate.
My left thumb indicates where my medial malleolus is. That is the medial malleolus. That's my lateral malleolus. Tibial spine. Femoral spine. Okay. One rotation like this and then done. My center of hip is recorded. In this range of movement, if you see, okay, go back. Back button is not working. Yeah. If you see the screen, you are able to see the screen. The last 2 boxes, if the green comes, that means patient is having recurvatum deformity. The last 2 boxes, you should not have any green signal. Spike, please. Yep. I am mapping the femur now. Just go around the borders of the femur. I have removed all the osteophytes.
So you always remove osteophyte before mapping?
Yes, that helps you to correct sizing.
Yeah, what Dr. JV does, always you have to remove osteophytes, meniscus before mapping.
This is the anterior cortex. That's the lateral cortex. 3D. Flex. Yeah. That's the posterior cortex. Yeah. Flex some more. Yeah. Done. That is my axis. Spike. Come this way. Posterior spike. Yeah.
So you are doing PSD?
Yeah, I am doing legion, PSD with patella. Already I have prepared patella because I am waiting for you people. To save time, I have prepared patella. Now I am going around the border of the tibia. That will give me the exact size. That's all data it requires. We are into the planning screen. Before I go there, I will see the ligament laxity.
என்ன சர்ஜரி
Before planning your mechanical element or functional element, what is
I am going for an adjusted mechanical alignment only. I have been following mechanical alignment. See, if you see here in my extension, if you see the screen, the point where it is going beyond the neutral. That means patient has a few degrees of recurvatum. Remember that. See here. See, you can see that beyond the neutral end. Okay. I am stressing my medial collateral, lateral structures.
சி டைப்ல
So here there are not much of ligament tightness either on the medial side or lateral side. You can notice that it's all loose, probably recurvatum. So I should not do any soft tissue release or soft tissue balancing here. So now we are going for a planning screen. This is the most important thing. So I'll come for the first thing. It says 9.5 millimeter distal cut and 5.5 millimeter. Since it's a recurvatum, I should take less bone. I will go to 8 millimeter. I don't want recurvatum to happen post-surgical. And then in the bone model, see my femoral. If you see the yellow dot, can you see the yellow dot there where I'm doing?
Yeah.
I am below that. My component is below that. That means I'm going to overstuff in extension. Okay. And now my femur size, it is saying 4. No anterior orang, well flushed, no notching. Posteriorly, it's the right of the yellow dot, indicating that we are going to replace at the right place.
Correct.
And then my rotation, external rotation, we have to keep it. This is where sometimes we do mistakes. Then on the femur side, tibia side, normally we take 9 millimeter, normal side. Here I am taking only 8 to be sure, because ligament laxity is there. We don't know at the end of the procedure. If you want to take extra bone, I can take it. But if I take now, then you are in trouble. Okay? That's my...
Your cuts are small both on the femur and tibia side.
Yes, on the extension I want to tighten it. Slope at 4 degree, 3 degree slope, that's it. Good enough. We are trying to match the native slope here. Arun, you are okay now with this?
Yeah, Dr. JV, I think you take some more tibia, no?
You want to take?
Yes.
No, because clinically I was feeling
It will be perfect.
Sir, is it tight in
Less
flexion also,
tibia,
sir?
less tibia.
tight, no, loose in extension. That's the reason I'm little conservative here.
Yeah, superior tibia. Yep, perfect.
Yeah.
You got minus. So because
Yeah.
you're going to extension laxity, you plan for minus numbers.
Yes,
That's it.
yes.
Minus.
Okay.
Yeah.
My surgery is done here, so we have to go distal cut. Chuck nuts. Oh, no.
Sir, in valgus knee, sometimes we will see lateral canal hypoplasia. Those cases.
That what is showing there.
That's what we are taking less, no?
Yeah.
So somebody was telling the feel of a surgeon artistic. That's how we'll show here. Yeah.
So this is called a sculptor basically. So what you draw a CAD diagram, use this hand piece, it sculpts exactly what shape you want here.
That's all.
No, not really. See, there's no butterfly cut because it's a lax knee, so that he's not taking any notch. So color tells you whether you're taking more bone or not bone. Yeah. Somebody missed, tell I missed my saw, you can use saw.
Some red areas are there, good for cementation.
What? So summer has come, watermelon. We call it watermelon.
Yeah, I know. Pointer. That is where my cutting block will be there. Pin. The computer has decided the point at which your, see, the distal cut will give you flexion extension and varus valgus. Now this one will give you the sizing, anterior posterior placement of the component and the rotation. Yeah.
Can't do it.
Size 4 alana. Flex, somebody flex the knee. Yeah, sorry. So my vision will be at the down left, 0.2. So I maintain that in less than 1 degree. Okay?
Yeah.
And the, no, yeah. Pin code. Yeah, less than a degree. So. Small blade. That's my anterior chamfer. If in this camera we can see that grand piano sign is there on the femur anterior cut, indicating my external rotation is correct.
Yes, sir.
My femur part is done. If you are a seared surgeon, it's done at this point. Yeah. Done. Posterior spike, please.
So what is your femoral external rotation that you have?
I have taken for 3 degree external rotation.
Okay.
Okay?
So after you started using robo, your external rotation has changed?
Yeah, my mistakes on the valgus knee has reduced. Or else every time we used to mechanically put the line of the transepicondylar axis and we have to verify before we complete our cuts. But here, you are 100% sure with robotics you will never do internal rotation. Now I am coming to tibia. So.
share the techniques to make an straight platform, and then we are doing remaining with saw.
Yeah, so.
Yeah, he makes some shortcuts of the burr to assess the depth of the cut and then uses the saw. Yes.
The hard subchondral bone I removed.
And Dr. Srinivas sir, why don't you do the visualized cut for the tibia?
Huh?
Why don't you use the visualization cut for the tibia? Use for the femur?
I'll. This is the easiest thing.
Okay.
As Krishnagiran was mentioning, the more you use the drill, burr system, sometimes people have wrist pain. And this is again a surgeon's field. Orthoplasty surgeon, unless he has a gun in his hand, is never satisfied. Done. See, more or less, my cut is okay.
Yeah, yes. The lateral side is very
Green should
little
solve.
more.
Blur. I'll just check any posterior osteophytes. Posterior, any bone is there? Dr.
Dr. Prashant, do you find any difference between the QS and
In QS, probably we keep the knee in 110 degree flexion, and the rest job is done by robo. We don't interfere in between. And only when the job is done, then we go ahead to take out the remaining osteophytes.
okay? Do you use the burr?
It's birth basis.
Burr based.
சர்ஜரி போயிட்டு இருக்கோம் மேடம் அதுக்கப்புறம் சார் ஓகே ஸ்பீச்
Femur.
டாபிக் இருக்கு மேடம் அதுக்கப்புறம் இன்னொரு டாபிக்
Dr. Srinivas planning CR knee here.
ஓகே
Yes.
மேடம் இருக்காங்க மேடம் கொஸ்டின் ஓகே மேடம்
PS. So PS knee.
So after getting robo, you are more inclined toward doing a CR knee.
No. I am from my talk. I am telling I am not changed my practice. I am a PS surgeon with Patela. I have been continuing doing that. No, no. I have been trained in PSD. I am very comfortable in all deformities, so that's it. It's your preference. I'm sure we all grew up with PFC Sigma, right?
Yes. How about you allowing your patients for squatting? Following
I
the-
don't suggest them, sir. Some people squat without our permission. I don't suggest them.
So your post-op rehab protocol has changed after robo?
Patients are comfortable more compared to conventional surgery. Reason being, our soft tissue release has reduced.
Do you discharge them faster than what you were doing earlier?
No, sir. Our patients are so happy to lie down here 10 days in the hospital. Hammer koda, counter koda.
So the concept of early discharge doesn't work up here. Are we right?
Early discharge.
Following robotic surgery, they say reduce hospitalization.
What size is this?
Cost for the hospitalization. Those things, do they really work?
To some extent it is working, sir. We are discharging in 4th or 5th day. Earlier we used to give 10th day. So in that way, the robo cost is compensated to some extent.
Here we always discharge on the 5th day.
So I was about to ask just after Somsekhar sir's talk actually, how far it's really working actually. In abroad they are doing daycare surgeries actually without robo.
Can you see here?
Yes, sir.
This is my alignment I've got. So 6 degrees flexion, that means little recurvatum or neutral is in, whereas 1 degree. So I have not fixed my tibia. This is the final image you have got. See, ligaments are correct, less than 1 millimeter laxity. A little bit of extension I will put. Now this is 9 alva. 11 inside. Go back. Now I am going for 11 insert. Flex, flex, flex.
ನವೀನ್ ಬೇಸಮ್ಮ ಅವನಿಲ್ಲ ಸುಮಾರು ಕೊಟ್ಕೊಂಡು ಬಂದಿದ್ದಾನೆ ನಮ್ಮ ಹಾಸ್ಪಿಟಲ್ ಮಾರ್ಕ್ ವச்சு
11 is difficult to go, sir?
ಮಂಡೇ
No, no, see.
ಮಾರ್ಕ್ வச்சிருங்கப்பா.
Yeah, now it.
Now it's correct?
Yes, yes.
Is extension tight, sir? The flexion
No,
is
no,
6
no.
degree.
No, 6 degree I accept. If I go at 0, that means you are in recurvatum.
So can you show the balancing with the varus and valgus stress, sir?
See, now I will show. Now so it is tight between 2 to 3 millimeter. I have increased my insert by 2 millimeters, so you can see from 1 to it has gone to 3 some places. But clinically, this is good, stable knee, mild anteropostural laxity. I think I should take this 11. What do you say, audience say?
Yeah, well agreed, because it was going for a hyperextension.
Yeah, no, here now it's better.
9 insert, yes.
And I mark my rotation here. My robotic work is done. Only thing I have to implant now. At this point, usually I disconnect robo. You want me to?
You can disconnect and go for the implant.
You can disconnect, right?
Prashant?
So we hardly took only 15 minutes.
Yeah, well,
So I have to prepare tibia and implant. Femur size 4, insert is 11 millimeter. Close. I don't think any other system you can do as fast as this one.
Now, you mean to say the system of J.V. Srinivas?
Cement open model, 4 female open model, 4 standard. Posterior is 5.
So you slightly felt it slightly tight. Do you do anything on the cementing, or you have anything to adjust on the cementing part, or you go floating cementing?
No, we increase the poly thickness, right?
Yeah.
That's what it is. And we checked it in the ligaments also, last ligament balancing. So that was good. We accepted it. All this.
So we'll be proceeding with the talk, sir. And
please.
Cementing, and we'll come back.
Please go ahead.
Thank you. It was a good demonstration.
We will continue with the next session on experience, complications, and tips and tricks in robotic TKR session. We request Muralidharan sir, our past president, to chair the session. Sure, sir. Sir, we can, you know,
So we'll be proceeding to the next topic. That is next session, that is session on experience, complication, and tips on robotic TKR. I request Dr. Shiv Kumar, our well-known surgeon, to come on the stage for the next talk. He will be speaking about his experience in his first 100 robotic knees.
Respected chairpersons, Dr. Muralidharan sir, Prashant, Vinod, and august audience. So after getting the robo in Madurai, we proceeded with all the cases with the robo, almost all the cases with the robo. And today I just wanted to share some experience of what we had through the robo in our setup. So this is what presentation goes on. And let me finish off very shortly. And first I thought that getting robo is a marketing strategy, which everybody thinks in the same way, similar way. Of course, it's there as a marketing strategy, it's there, but even the company people try to intrude into your mind that, sir, you should be the first, and you should be the first in this center, and you are the first robotic surgeon. So these are all the words any industrial person will try to use in you. So that was the beginning of my introduction with the company people, and slowly when we went into the details of the robos and how it was very useful in helping us in planning the cases, then my concept also changed. So the concept changed with this McDessie's classification of CPAC, where the alignment philosophies came, and of all the 9 boxes, first 3 boxes hold good with the joint line obliquity, which is more distal, and the first 2 holds 50 to 60% of the cases. So there are, of course, there are many reasons for a painful knee replacement, and the most things which could be addressed by robo, which I felt is malalignment and patellar tracking, and leading on to instability also. So these are the areas where these robos can help, and this is the entire discussion which is going on for the past 1.5 days. So I started my TKR way back in 2006, and from conventional to robo assisted TKR, and now the robo UKA is the new kid in the block, and we had a half a day session on the UKAs also. So from conventional, then came the navigation, the patient-specific instrumentation, and then now it's the robo. That is, the navigation is the first phase, followed by robotic technology as the second phase. And this is where we are all evolving into. And in future, we may have to be living like this in a virtual world along with the reality, and we may have to adopt certain virtualities, and the technologies has to be incorporated in our real life. So this is one thing. So just we went for a tour, I found that there is a robo keeper. I was also told even in India it's there. So the goalkeeper, the robo is fixed and it never allows inside. That's what they say. The technology has grown. And the technology has grown in such a way that we go for advanced driver assistance systems. We have driverless cars, and even in the homes, even 10 years before itself, in my home, we have these robo cleaning machines, which adopts the LiDAR navigation system. First, it maps the area using that area, and then it set a time and it moves at the same time. It goes and again recharges also. So even if it doesn't require any feeding, so that's how it goes. So we may have to go for this adoption of technologies, and we may have to go. So we all pretty well know AI is coming, we have to go for that. So what I feel the differences between the conventional and the robo-assisted knees are, the pros will be shorter time in conventional. You can finish up in some 30 to 40 minutes on an average very quickly. Some people claim 20 minutes, and they had reasonable buggings even right from abroad. Some of the centers claimed 20 minutes, then they said it's not the right way to explain the public. Shorter time, it's time tested, shorter learning curves, and the cons will be the alignment issues, especially the malalignment, patellar tracking, and the consistency and predictability of these alignments will not be there in the conventional TKA. And again, it's unable to quantify, and most of the time you take the tibial cut through eyeballing. Whereas robos, you go with accurate cuts, decide on the type of alignment, quantify the gaps and the sections. But of course, it is costlier, time consuming. Initial early learning phase, it may be around 50 minutes, it may be 30 minutes beyond your normal schedule. Slowly you can bring it down to 10 more minutes from what you do in the conventional procedure. So what I learned during the transition was the patience. You understand the deformities, you quantify the gaps and cuts, and then the post-op measurement was very much consistent, and that's what we were able to see all these few months. So this is one of the famous landmark paper to show that is neutral mechanical alignment normal for all patients, and the concept of constitutional varus. So this is very, very important, the constitutional varus. So we started observing our patients in our region here, those with back pain, with the knee pain and hip related problems. So even those patients with back pain had back pain secondary to osteoarthritis of the knees. So these are all the next levels of studies which we may have to go, and the alignment saga which I explained. Of course, there are a lot of alignments, but what alignment is well accepted, even yesterday by Krishna Kiran was told the functional alignment is the one which is well accepted, which is an emerging philosophy that aims to reconstruct a 3D constitutional alignment while respecting the behavior of the soft tissue envelope. So you go along with the constitutional alignment and place the implants in such a way that you respect the soft tissue envelope. This is the using the robotic platform. This is the functional alignment. And a small audit was made with our cases which we have done, and so we have put as an internal audit. It is subject to change then and there, and the aim was to assess the functional alignment using the Cori system in OA knees with varus deformity. And this is the methodology. We did around 106 cases over the period of 6 months. And of course, the follow-up and all, some cases we have done, most of the cases we have done 3 months follow-up, and some cases are very short for follow-up. And 82 knees with the varus deformities were studied, and still we are continuing also. Of course, all the slides I can rush because most of the discussion has been over for the past 2 days, and the duration we have reduced it to 70 minutes, 60 to 70 minutes, including the cementation time. Yesterday you were also able to see that average hemoglobin drop was 1.8 grams, and the average pre-op varus, which was 8 degrees, we had only 2 degrees. And the FFT also, which was around 8 degrees, it came to 2.6 degrees in our robo-assisted cases. The gap balancing, the medial and lateral laxity, it was almost nearly within a millimeter's laxity. That was the one which we are aiming at. These are the So what we aimed, the functional alignment was the varus between 1 and 3 degrees. So from 0 to 3 on the varus side and 0 to 3 on the valgus side. This was our aim, and we were able to achieve consistently and persistently. The post-operative pain was significantly reduced, and the need for analgesics reduced drastically. So that's why most of the time we don't go for a local cocktail because of the risk of infection or something else. We are a bit bothered about it. Many people they go for that. Of course, there is a good relief for the first 24 hours, which is well done with even with the regular epidural and the adductor blocks. So the time needed for the patients to return to normalcy has been reduced, but still we were not able to quantify it. And the Oxford knee scoring system was also good to excellent in the follow-up of 3 months. The complications, we had complications. One patient had bilateral wound soakage, and one we thought it's only a fat necrosis. The second knee also got infected, and we have done a dire procedure for that patient, and patient is doing well. And one patient has an inflammatory reaction. Maybe we thought in the bone dust could produce an inflammatory reaction, and it was treated by a course of steroids, and patient became all right. And one patient with severe osteoporosis, where the patient was rheumatoid, we operated with robo, and patient had a periprosthetic fracture with an unstable implant, where the patient was done a distal femoral resection, and patient has been salvaged with that DFR. So in the robo, we were able to achieve functional alignment with calculated soft tissue release, calculated bone cuts, and minimal bone loss. We were able to choose an adequate size, appropriate size, and sometimes even a bigger size. Most of the time, we tend to reduce the size, which may not be appropriate for the patient. And sometimes we overstep also. So the optimal size will be chosen, and almost all the inserts were almost 9 mm, except for a few cases of laxity like what JVS was demonstrating. So improved post-operative limb alignment and clinical function at the final follow-up was there for these patients. Of course, these slides I can skip because all these things have been discussed, the detailing and what all changes we have done apart from the books which are given in the by the industry. So this is the last slide. So I want to use the robo because of these reasons. Most of the cases, 99% of my cases, it's better to use the robo. Both varus and valgus and even inflammatory conditions, it's better to use the robos. Use of pins locations varies on the basis of the osteoporosis and soft bones. So if the patient is severely osteoporotic, the patient has not walked for a long time, never use the robos. So that's one of the learning point. They go for fractures. The stress fractures incidence is very high because of the use of the tracker pins. Need absolute functional alignment, not possible without the robos. And when to think twice before using the robo when the deformity is more than 20 to 30 degrees on either planes. Of course, Dr. Tejas was demonstrating up to 28 degrees of varus, but in the initial phase or up to, because you are tensioning of the soft tissues, you may not be able to do adequate tensioning and you may not be able to do adequate gap assessment in severe deformities. And severe osteoporosis, as I have already told you, it's better to avoid. Extra-articular deformities, it doesn't help much. The robo doesn't help much. Thank you very much. Thank you.
Sir, if you find when you are cutting distal femoral cuts, your medial and lateral cuts are different compared to conventional cut when you are doing with robo. Is it so? Because we are doing maximum bone cut to match the ligament balance. So, but when we are using a blade in conventional TKR, when we cut the distal femoral cut, it always a straight cut, which we cannot account for the varus valgus alignment of the soft tissue. But when you are doing with the robo, are you cutting less when, on the loose side and more on the tight side?
Yes.
Is it so?
Yes, yes.
The difference will cut in the distal femoral cut is there.
There is a difference. Like what you do in the conventional, you go for a 9 mm on the unaffected side and you take some flushing over the trochlea and then to a little extent on the affected side. That's what you do. Here also almost the similar cuts only, but not like that of 9 mm exactly. So because you distalize the femur when you are doing a gap assessment and implant planning, so you distalize the femur. So based on that, you have to go for a distal femoral cut.
So after the cut, it will never look like a butterfly shape. So that's what we conventionally.
Yes, yes. The kissing sign, the butterfly sign, that will not be there.
Okay.
It all depends on what planning you do.
Okay. But the implant fits well.
Implant fits very well. Implant fits very well.
Thank you, sir.
Thank you, Dr. Sokmal, for sharing your experience with the first century in robotic knee surgeries. But out of 106 cases, the complications you had only one inflammatory reactions and one mild infection.
One infection.
Yeah. How about the other conventional arthroplasty cases? How many complications you had approximately? Do you find any difference between in complication rate between the conventional TKR and the robotic TKR?
We don't have an exact study of the conventional one, but as per the literature, you know pretty well, up to 1 to 2 mm of infection can happen for any case for that matter. So here also out of 100 cases, one case I had, maybe 100 means 2 knees. We had one, we suspected only a superficial fat necrosis. In the second one, we had an infection, we had a growth, we picked up the germ also. So that is 1%.
Minimal.
Yes.
But before that, you were doing conventional TKRs. In those cases, how about the complications? Is it? Do you think that is more on conventional cases, or it's the same?
It's almost the same.
So, with the robotic surgery, does your knee FFDs and post-operative range of movement are better compared to your conventional surgeries? The usually post TKR, sometimes we have 2 to 3 degree of, sometimes 5 to 8 degree of flexion deformity, which physiotherapy will be stressing to correct it. So such an incidence is less with robotic. What I mean to say is that do you feel that ligament balancing is happening better with the robotic surgery?
definitely ligament balancing is much better with the robotics. But as far the FFD is concerned, if you are going along with the robos, sometimes you have a flexion deformity of 5 to 10 degrees, which even the people say to accept. But in that situation, I do a minimal posterior capsular release and then I correct the FFD. I don't allow the FFD to happen. Clinically, it should be completely zero.
It is your clinical vision, not on the robo.
Yes, yes, yes. Correct.
Thank you, sir. Thank you very much.